as health and nutrition enablers at home. And for that, I will now give it over to Sarita.
There is this understanding which we all say that India is a patriarchal society, therefore our behaviors are largely governed by how society perceives what men and women should do. And when society perceives women should be the caring, should perform the caring roles, and men should also be in a role of provider. So if we are able to expand that role of a provider as a caregiver as well, that is what we have to cross the bridge for. And therefore, what we have attempted as an experiment, as a pilot, we did it in Chhattisgarh and in Bastar block. And our research evidence now shows that when you intervene, you work in a methodology as a strategy to engage men and communities, you are able to make a positive change, a change towards men more as enabler, specifically to improve outcomes for food, nutrition, and childcare. And let me just put you across to certain, figures and data. For example, there are studies done in Cambodia, there are studies done in Bangladesh, there are studies carried out in India. So in our Southeast Asia and Africa, which are the developing nations, we find that there are few pilots which have tried to establish that to change the complementary feeding practices, to change institutional delivery practices, which ultimately influence the family's decision making on where to, go for the delivery of the child. What would a woman be able to eat immediately after delivery? How soon a baby is put to the mother's breast? If there is anything given to the child before mother starts breastfeeding, can we make some changes which are more positive change behaviors, and if we can show them through certain role models. So what I would like to highlight, the what you can see on the screen right now, is that I will definitely be happy to take your questions, but since I'm just trying to highlight this one slide, so I will first try to explain that to you. So our experiment started with a pilot, as I said, done in Bastar. And in Bastar, we use, because there was research going on already in that area, where young adolescent girls and women were being exposed to information on positive changes in health which is required. For example, how to prevent anemia, use of iron folic acid tablets, going for institutional delivery, husband and wife, the young couple coming to a Mahila Mandal meeting and receiving a suitcase in which there were essential things which were being provided, which these essential things were like the use of the contraceptive and things of this kind. And because in marriage, as you receive gifts, so it was considered as a continuation of that ritual. So it is a kind of a community event where that new couple is invited. They are gifted with this suitcase, which has all the essential things, including umbrella and few such things, which are required in the community. And plus, in addition to, have a conversation around use of contraception and be delaying the pregnancy, as in certain norms, we know that as soon as a couple gets married, there are expectations to have a baby soon. So in order to do that, this kind of a ritual which helps to break the ice and have conversation. And because in Mahila Mandal meetings, otherwise men don't come. So we had this experience, and therefore working for some time, and when the research study reached up to the time of mid review, we realized that certain indicators were not moving, and we really needed to something more intensive to understand that why these indicators were not shifting the way we wished them to. And it we realized in our conversations with young women, adolescent girls, that it is the family environment, because they are not the sole decision makers. So it is the family environment which helps them to do certain things, or which kinds of creates resistance for certain actions. For example, going for antenatal checkups or going for institutional delivery. So these were certain things which they mentioned in the conversations, that it is if the family is also of the same view or enables it, they are able to change. Otherwise, this change is difficult to bring in. So that brought us to a kind of a back to the table, and where we said that because we were working with women's self-help groups, which by design are supposed to be working only with women. And therefore, how do we interact with men if women are saying that if you keep talking to us, there is a ceiling, we hit a ceiling. And therefore, we have to expand the scope of our conversation. And the conversation is not, this is just not individual talking to a woman or a girl, not just family, but also at the community level, the setting. Because if you have to shift social norms, talking to individuals or families is not enough. If you are setting up or moving towards setting up an alternate norm, you have to have a community acceptance to that idea. Very few people will have the courage to have this battle at an individual level. But if we are able to create that environment of acceptance to an alternate norm, it becomes easy for families to take decisions accordingly. So the strategy, we worked with several organizations which had been working with mainstreaming men's into participation development and various other experiments. Various organizations came, and learning from that, we wanted to understand that what in our that particular context was an opportunity to talk to men and community. So this is what this picture is talking about. So we used 3x3 strategy, wherein beyond the women self-help group members and the adolescent girls, we wanted to tap into the power and the potential of decision making of husbands, mother-in-laws, and local healers. And for them to come together, because they technically cannot come into a self-help group meeting, which is a women's group meeting, which is around economic gains, and therefore it becomes an attraction for women to come to these meetings because they can take loans and they can use those loans for families' consumption or investment purposes. So because this was an attractive window, and men, whenever we had these conversation or games, etc., interaction, we saw men standing on the periphery, being there, enjoying, and they wanted to, they would pass comments, they would say something, they wanted to be there, but they were actually technically not in the meeting. So experimented with this idea, and we used a potential platform within the community, which is Parivar Chaupal, which is a meeting once a month, which happens, wherein all the panchayat members, all the frontline health workers, and all these women and men are there. And our Poshan Sakhi, or our women community resource person, which has been given the responsibility to have conversations around nutrition, she was able to mobilize these people. And again, there was an experiment wherein we divided the 3x3 strategy was these three target groups, and three key messages were that we did not want our young mothers to eat last and least. So that was our first crucial message. Second was no early marriage. And third was after marriage, planned pregnancies and space between the pregnancies, because these three things will ultimately lead to better health outcomes. So looking at this 3x3 strategy, so engagement of community, PRI members, frontline health workers, and in our context, it was Sira Gunia, the local healers, who also made a lot of influence, specifically in terms of institutional delivery and antenatal checkups. So this is how, Saroj, you can remove this slide now. Thank you. So this is how the what the strategy was all about, and it showed us that it had an influence because we were able to speak to men. And another hurdle which Rajdeep highlighted, because communities are used to hearing men as information providers, men as providers in general, providers of food, provider of health services, providers of information, making families take services, whether it is a service from a PDS, service from a health functionary, going out to seek any help, any kind of entitlements, the men take the lead role. But our community resource people who are women and have been doing that for the group. So for them, we first had to cross that hurdle of building their capacities to address a group within the village community where men as well as women both were sitting. And it took us 1 full year to complete that capacity building process, wherein those women said that yes, they feel now capable to speak about that. They were able to overcome that resistance of because elderly men, elderly women of their communities were sitting in the same groups, and if they had to address a meeting, it took a lot of courage and lot of shedding a lot of inhibitions to talk amongst them. And after that, once this set was done, we divided our meetings into 8 meetings. So as I said, 1 meeting in a month. So every meeting goes with one key message, and we divided it into life cycle approach. So we started with talking about early marriage. We then that why it is important to delay marriage, why it is important to have a body which is able to give a birth to a healthy child, and the maturity of the couple who is taking a decision to get into parenthood. So this conversation became important. So there were inhibitions to talk about family planning. Now we see that our young Poshan Sakhis are able to talk about alternatives available for family planning, etc. So then we moved on to antenatal checkups, we moved on to institutional delivery, then we go on to talking about postnatal care, immunization. We then are able to talk about the achievement of right milestones for the health. And then our focus comes on to talking about nutritious food, and then talking about the myths and myth conceptions regarding food. For example, what to eat, what not to eat. There are conceptions about which part. For example, in Bastar, we found that fish eating is a common food practice. So it is not that non-vegetarian food is not eaten, but which part of the fish is eaten by whom becomes a key this thing, because something which is considered to be more nutritious is generally served to men and boys, and something which is considered not so nutritious or more gravy or more diluted form of it is consumed by women. So our conversations are around this. And then the last is about the care for the child. So care, giving bath to the child, cooking a complimentary food meal for a child, use of Shri Anna, which was being promoted 2 years ago when we started this experiment. So we kept one of the meetings wherein we talked about the kodo, kutki, which are the local millets which are to be consumed there. So, what I'm trying to convey here is that there are possibilities, and this kind of efforts to engage men into conversations around women's nutrition and health, where we use their agency and the traditional viewpoint that they are the providers, we make them as in the conversation through the role modeling, that they definitely, it's an extension of that role, which is much more than just bringing money to the family. It is that what do we do with that money, how optimally, how well we can utilize it, and also being insensitive to that. We I just if time will permit, Saroj will play that film, that if the family can eat just one meal together, we will be able to kind of offset certain biases. So these are certain things we have been able to do. But to say that this is something very easy to do, or it will not have any kind of hurdles, uh, it will be naive. We all understand that there are challenges. We also face certain challenges, and more than us, it was the group of our community resource women who told us that this is and these I talked about these 8 meetings. So what will go into each meeting, with what game will this be done? There will be a taraju game, or there will be different, the methodology to transact on those issues were co-created with the women. So it was a participatory engagement. If the people here already know about PLA, participatory learning and action, so we use those techniques to conduct this meeting, which goes on for about 30 to 45 minutes, talks to men, has role for everybody. And then they are able to kind of set up, people would laugh, enjoy, reflect. And in the initial meeting, sometimes men are quiet. Gradually, after third or fourth meeting, they start coming out, they start talking. And once they start talking and show a kind of an ownership to this change of an idea, we feel that this becomes possible. And for communities to adapt to a certain behavior, they're not only convinced when they see it on a film or a movie or a show or a role play. Once they see it happening very close in the neighborhood, in the community, that is when they are able to have that courage to make that change for themselves.